All right, any questions from the first half? I'll check it at the end. Yeah, we'll go back through that. All right, so we're going to move into the OB-GYN section. Gentlemen, don't worry. We'll get to our section later on. Talk about some urology stuff later on that more has to do with us. But this is now the time to focus on the ladies. It is hers day. It is Valentine's Day. Let's focus on them a little bit. I'm just kidding. Now, my general caveats, I barely understand how women work. How I'm still married is a complete mystery to me. So just be aware of that, right? If you have any questions, we can always consult some experts. Probably Professor Lack or somebody like that. They can help us out, right? Anyway. Oh, man, I hope she doesn't listen to this stuff. She would probably be very mad at the oversharing that I do in this class. Anyway, so let's talk a little bit about pregnancy and lactation. We'll start off with that, and then we'll move into the actual gynecology section, secondary. So a little bit of history about pregnancy and lactation. I normally think about, like, how many drugs do you want to give to a pregnant woman? 0, preferably, right? You'd like to give nothing other than, like, maybe a multivitamin, prenatal vitamin, preferably to these patients, right? Can you take a prenatal vitamin during pregnancy? Yeah, you absolutely can, right? You probably should continue taking a prenatal, because again, they're developing a little human, right? They need all the vitamins and minerals they can get, right? So anyway, so back in the day, the reason why we have so many laws around and regulations around drug use in pregnancy actually had to do with a drug called thalidomide. Anyone ever heard of thalidomide before? It was actually something that was used back in the kind of late 50s. It came out, it's actually used as an anxiolytic for pregnant women. It was actually used over in the UK and in Europe. Fortunately, we never had any cases over here, but what they actually found was that it had this teratogenic effect. When I say teratogenic, what does that mean? Basically harming the fetus, right? It's basically causing birth defects and things like that. So what they actually found is they had this limb malformations. They actually kind of had these kind of flipper sort of like appearances for these kids who were actually exposed to thalidomide in utero. So obviously that's a very horrible consequence of that. And so we realized, okay, well, we don't want to use that here. And so fortunately, thalidomide never really got used over here too much. You'll still see it used very, very, very occasionally for certain types of cancer treatment. However, they started to see, like, well, we probably need some better ideas about what this is going to do to people before we give it to them, especially pregnant women, what kind of effects it might actually have on developing fetuses. And so that's where we actually came out with this Kefauver-Harris drug amendment to the FD&C Act, so the Food, Drug, and Cosmetic Act. And that's what regulates a lot of things like when do drugs get put onto the market, regulates things like, food standards and cosmetic standards, et cetera, right? And so we basically said we probably need some evidence to show that this is safe to use in pregnant women before we start to give it to pregnant women. So, and again, we're seeing that more and more drug use in pregnant women is being used. We're treating more things like hypertension, we're treating things like diabetes, we're treating things like, depression. And so again, we can expect to see that rise to continue to go on. And so we need to have a better idea about what's safe to use in pregnant women, what's not safe, and how to manage these patients, right? So anyway, and so a lot of these women are going to be taking things like over-the-counter medications. Now, just because it's over-the-counter, does that mean it's immediately safe? I mean, aspirin's over the counter. You can kill someone with that pretty easily, right? Acetaminophen's over the counter. You can certainly kill yourself with that. So not all these medications are always going to be considered to be the absolute safest. Some of them are very safe. So for instance, acetaminophen in therapeutic doses, very, very safe in pregnant women, right? Other things, maybe not so much, right? So for instance, using things like ibuprofen or other NSAIDs in later stages of pregnancy is actually a big no-no because it can do things to the ductus arteriosus in that fetus and affect their blood flow, right? Just as an example. Just because it's over the counter doesn't mean it's immediately safe, those patients. We still see a lot of drug use because it is over the counter. And as you, as a provider, are you always going to know when your patients are using over the counter drugs? Frequently not, right? But unless you ask a question, you're definitely not going to know, okay? Also, we're starting to see much more antidepressant use during pregnancy. We know this is a big deal, and we'll talk about this a little bit later. Again, it's hard to find good recent numbers for that, but it does appear that trend is still continuing to rise. And so you're seeing more women who are being exposed to antidepressants during the pregnancy period. So, as I mentioned, teratogenesis is really any kind of significant postnatal change, either, say, in function or in the form of the offspring after prenatal treatment, right? So the mom's been treated with a drug and caused some sort of deleterious effect to that fetus. Can either lead to congenital anomalies or these malformations that can occur here. So it could be as severe as something like a limb malformation. It could be something like, cardiac defects. It could be all sorts of different problems that develop from this. There are certain types of cancers that are actually have been linked. So actually, women who develop endometrial cancer in their 30s and 40s that were actually linked back to maternal drug exposure in utero, right? So again, sometimes these things are really hard to determine, but even things that are that disparate as far as time goes can be influential here, right? Anyway, so some examples of known teratogens. This is not an all-inclusive list, but these are things maybe we've talked about before that we know are really big no-nos as far as exposure in pregnant women. And in fact, you also have to think about who also is being exposed to these drugs as well. So think about the hospital setting. Who could be exposed to these medications? They're not receiving them. Nurses, pharmacy personnel, other family members and things like that. So you have to think about these things. You have to make sure you're using appropriate precautions to make sure they don't have any kind of undue exposure that could put them at risk as well, right? So things like ACE inhibitors. The renin-angiotensin system is very, very important for developing fetuses. If you interrupt that, you can definitely see fetal demise potentially. You can see a lot of big birth defects from that. Things like cigarette smoking is going to cause some issues. Cocaine. Why might cocaine be a problem? A lot of vasoconstriction, right? That baby needs that blood flow, right? So that could be a problem you can see with that. Warfarin. Obviously, anytime you're messing with any kind of fat-soluble vitamins, no good for a fetus. So anything messing with vitamin K, it's not going to be good. It can cause bleeding in the fetus. Isotretinoin, Accutane, what vitamin does that affect? Vitamin A, absolutely. So vitamin A is a big thing with isotretinoin. That's going to be, and again, remember we talked about the REMS program, seen with that. You have to make sure that women are getting pregnancy tests done regularly. We have to make sure guys are educated on using prophylaxis, etc. Lithium, phenytoin, valproic acid. So a lot of disease states can be very difficult to treat when the woman gets pregnant, whether they have bipolar disorder, or they have seizure history, or anything like that. Anyone remember what I said valproic acid causes? Which causes neural tube defects in developing fetuses, right? So anyway, so there's a huge list of known teratogens. It's going to be impossible to know every single one of them, but these are some of the high-profile ones you think about as being really dangerous for some of these pregnant patients here. So how do we determine if something's teratogenic or not? How do we know? Animal studies are a big source, right? So we give them to little animals and sat for them, give the little offspring little birth defects. Was handy for us because then we have more information, right? But can you take that information? Is that completely one-to-one with human data? No, but sometimes it can give us some ideas, right? So at least if you're treating animals, you see this type of birth defect, and it stands to reason it could happen also in humans. It may not always happen, but it could. Well, how else might we determine that some of these drugs are teratogenic? Yeah, so potentially you have like anecdotal reports where you have something happen, you go back and look at the history, maybe there's something linked there. Now, the best way you can tell cause and effect relationships is what kind of study? Randomized controlled trials, right? However, is that ethical to take 100 pregnant women, give 50 of them this drug and 50 of them no drug, and then see how the babies turn out? No, that is very unethical, so we can't do that. So oftentimes what we're seeing is that we either have voluntary reporting systems, so that way if women do have these teratogenic effects, we can see if we can link these back. So if you see a large number of women who are being reported as having these teratogenic effects on their fetus, then maybe we can link that back to a potential drug. Case control studies, case reports, all these things are very useful for helping us to determine if there's any kind of link here. However, we cannot do randomized controlled trials, unfortunately. It's hard to do those good kind of studies. But you could do certainly like something like a cohort study where maybe women have been exposed to something. You could do case control studies, which are looking more retrospectively. These are things you can do to try to figure out what the heck's going on here. And so what we find is that animal studies cannot be directly extrapolated, but they also provide a key bit of information here as well. Okay, and so basically, and what does the pharmaceutical industry always say to do a little bit of CYA on their part? If you can avoid it, don't use it, right? It's always a risk versus benefit sort of thing here. And so I say, well, we don't know. There could be a 1 in a million sort of effect here, 1 in a billion that could happen to your particular baby. But we say don't use it if you don't have to, right? That way they kind of cover themselves. However, we don't always have that benefit, right? Sometimes we have to treat these patients without all the information there. When do you think is the most critical part of the fetus's development that we worry about drug exposure in? First trimester, right? Because what's happening there? Organogenesis, right? When you're actually developing all these organs, that's when the baby is going to be most likely affected by drug exposure. So typically when you think about drug exposure, you think about the first trimester as being kind of the most sensitive period there, right? Because all the organs are forming. The rest of the time, usually it's just a lot of growth and maturation occurring at that point. The organs are already kind of formed there. However, that's not always going to be the case. So for instance, like with NSAIDs, you actually find that they tend to be like a category B or C, like during the first 2 trimesters, and they turn to a D at the last trimester. Right, so we'll look at different options. I'll talk about the categories here in just a few moments. But just know it's not always the case, but typically first trimester is the most sensitive period. Anyway, so some of our factors we're looking at these drug effects here. So again, as I mentioned, the stage of pregnancy makes a difference. We'll talk about NSAIDs real briefly and how that has a route there. How do you think route of administration makes a difference here? Effects of bioavailability, right? So the higher the bioavailability, the bigger the dose the fetus might be experiencing, right? So imagine someone who's abusing cocaine. What has a higher bioavailability if they were, say, snorting it or if they were injecting it? Injecting it, right? Because that's 100% bioavailability. You could have a higher amount of drug being exposed to that fetus. And we know the fancy name for snorting? Insufflation, right? It sounds like a fancy French dessert or something like that, but insufflation is the term we use for snorting substances. But obviously the dose, the duration, how long they were abusing. I mean, you'll have these women who will potentially be abusing illicit substances throughout the entire pregnancy. And what do you think happens to that fetus when they come out of the mom? They're still expecting to get those drugs, and all of a sudden they're not getting those drugs anymore. So what happens to them? Withdrawal, right? Absolutely. What do you call that? Neonatal abstinence syndrome. If you ever heard NAS, and unfortunately we see way too much of that in the NICUs, especially in, if you think about like different types of hospitals. So for instance, freestanding children's hospital, we don't have anyone being born there, hopefully. So we get a lot of transfer of sick kids in, and those kids tend to be more likely to see a lot of neonatal abstinence syndrome. That can lead to a lot of issues. They're withdrawing, they don't feed right, their temperatures can't regulate that very well. All kinds of issues with that. So we can talk about that briefly, but that's unfortunately something we see a little too often. But yeah, I think the other things to consider. But the effects could be things like obviously the worst thing could be destruction of the fetus, but you can also see structural anomalies, growth retardation, CNS abnormalities, all kinds of effects. The whole gamut can be run here as far as effects from drug exposure. So the general considerations, and we kind of talked about this briefly back in pharmacokinetics, but what are things that allow for drugs to more easily cross a biologic membrane? Because again, crossing the placenta is a biologic membrane. What are some things that help drugs to cross more easily? Is it lipophilic or not? So the more lipophilic a drug, the easier it can cross. Okay, it's a good one. What else? The charge on it, good. So less charge or more charge makes it easier? Less charge. If there's no charge on it, it makes it more lipophilic, right? It falls right back into that. What's interesting, you can actually have what we call ion trapping, where basically the pH changes subtly between, say, the maternal pH versus the pH in the amniotic sac. And what you find is that as it crosses over, it changes enough to where it puts a charge on that drug, and then guess what? It can get over, but it can't get back out. So now you have increased concentrations. You have the drug concentrating there, and where the fetus can be more likely to be exposed to it, right? What do you think about the molecular weight? What makes it more easy to cross? Smaller or bigger molecules? Smaller is easier to cross, right? And then what about protein binding? What do you think? Less protein binding, right? So the more of it that's freely floating in the blood, the more of it that can potentially cross over, versus very tightly protein bound, more likely to hold on and stay in the maternal circulation. So these are all kind of general considerations we think about as far as how easy it is for drugs to cross over and have effects on that fetus. Now there is some ways that the fetus is going to be somewhat protected. So the placenta itself is a semi-permeable barrier, so it has some ability to prevent certain things from crossing over, whether it be too large or more hydrophilic substances. But there's also a little bit amount of drug metabolism that actually happens in the placenta as well. So it's able to kind of protect itself a little bit by having some drug metabolism there. However, a lot of the drug can also enter the fetus through the umbilical vein. And so by that time, about 60% of that blood is going to be going through the fetal liver. Now, we talked about pediatrics before, and how good are their livers when they first are born? Not great, but there's still some metabolism that can happen there, right? So the liver is still somewhat functional. You can still get a little bit of metabolism that may be helping to prevent further exposure to the fetus, okay? At least get some of that drug. So all that goes into the pregnancy categories, right? And actually what you're finding with a lot of new drugs is that the categories aren't as useful as you would think, right? And so we'll talk about 5 main categories. There's A, B, C, D, and X. So someone didn't learn the ABCs very well in kindergarten, but that's what we got, right? So A, B, C, D, and X. Which one's the worst, do you think? X, right? D would obviously be very bad as well. And then you have A, B, and C. A being obviously the safest, we think. B being a little less safe. C, we're going to find that's kind of the kitchen drawer of wayward electronics, right? Kind of everything just gets shoved into category C, so to speak. Does everyone have that kind of drawer in their house or at their parents' house? Right, that's kind of what we're talking about. But A basically means that we've had no studies that really show any demonstrable effect, negative effects on human women, basically, right? So again, we've had drugs that have been around for a very long time. We've done studies potentially that show no risk to the fetus in human women. Okay, so that's great. It's nice that we have category A drugs because we know that we're feel very, very safe that this is going to be a very safe drug for that patient, right? Think about things like Tylenol fit into category A. Think about things like vitamins fit into category A. Very, very safe. Category B kind of gets a little bit more nebulous. Kind of says that, okay, well, there's maybe animal studies that don't indicate risk, but we don't have any randomized controlled trials for human women to show us any risk, so we're maybe not quite as sure. Or if we have animal studies that have indicated risk to their fetuses, but we have human data that shows us there's no big problem there. That would actually get filed into category B. So if you had to give a drug to a woman, and you had your pick, A or B are probably going to be your two best bets, right? Those are the ones we have the most safety data with. I would feel very comfortable giving that. Say, for instance, to my wife if she were to become pregnant again. God forbid, but just in case she gets pregnant again, especially after last night, if she gets pregnant again, I don't know. Anyway, but A or B, very, very safe. I feel comfortable there. Now, as I mentioned, C is going to be that kitchen drawer where basically everything we're like, oh, we're not really sure. We don't really have any good evidence. The animal studies may not be all that conclusive. Maybe there's a little bit of risk, maybe not, but we're not really sure. It becomes very much a risk versus benefit sort of thing you have to weigh there. And again, where do you think most drugs probably fall into? Category C. So as a clinician, is that super useful to you? If it says, oh, not really, right? So again, we're going to find there's some labeling changes. And when you look in things like Lexicomp and things like that, you'll find that they give you a little bit more information now than just a simple letter. And that can actually be much more useful, and it allows you, as a clinician, to start to use your noodle a little bit to critically think about whether this drug is, whether the benefits are going to outweigh the risk to that woman and that fetus, right? D, we definitely know there's positive, negative effects. That's an oxymoron, right? We definitely know there's negative effects on the fetus that happen there, but there could be scenarios where the risk to the fetus are outweighed by the benefits to the mother potentially, right? Because again, if you're in a life-threatening situation, if you lose the mom, you lose the fetus as well, right? So again, there could be cases there where you know there's fetal harm, you may have to treat the woman. Very rarely you run into those circumstances, but something like warfarin actually fits into a category D, but again, very rarely you'd actually need to do that. Category X means it's absolutely contraindicated. There's no scenario where the risks outweigh the benefit, or the benefits outweigh the risk. Just not going to use it. So like Accutane, is there any period where a woman absolutely needs to be treated for her acne while pregnant? Nah, we're just going to let her deal with it, right? She can get on after pregnancy, after she's done breastfeeding, all that. So it's a category X in that case there. It's absolutely contraindicated. Also, we have to consider what is the lactation effects, right? So we have to think about things crossing over into the breast milk, being transferred over to the baby once it's born, right? So the same things happen here. We still think about things being more lipophilic, smaller molecules, non-charged molecules. All those are going to have an easier time crossing over and getting into the baby's GI tract. And what do we say about the baby's GI tract, especially very early on after birth? How's the acid production? It's not great for the first couple of days, right? The pH of the GI tract is going to be a lot more elevated than it would be after, say, a week or two. Their liver metabolism, we said, is not great. So again, you could still have a significant amount of drug exposure to a fetus just by transferring to the breast milk. What's a common thing you think like a woman may want to partake in after 9 months of carrying this thing around and going through all that labor, which you might want to partake in? Maybe a glass of wine, right? And she deserves it, 1000%. However, you have to think about alcohol can be somewhat lipophilic. It's able to cross over and get exposure to that fetus, right? And again, the liver can't really metabolize it that well, so you could have a significant transfer of alcohol that gets trapped in the breast milk, transferred over to the baby. I get not fetus anymore, to the baby, and they can actually have intoxicated infants that way, right? So we'll talk about some strategies to get around that a little bit later. But the same principles that go along with placental drug transfer go into breast milk drug transfer as well. Other things to think about as well, so like the time since delivery. So typically early on, you're going to have much larger gaps in the mammary alveolar cells that tend to close up over a period of weeks. So the larger the gaps, the easier it is for larger molecules to cross over. So you may actually find that after a few weeks or so, certain drugs may not cross as easily, less likely to see infant drug exposure. And then also looking at things like the maternal serum concentration. So the higher the concentration is in the mom, just like we saw with transfer, say, across the skin, the higher the concentration is on one side versus the other, the more transfer you get. So if mom's BAC is like 0.4, she was really done with that pregnancy, and she's like, let me go hit the bars, that you're going to see a lot more transfer to the infant than if it was, say, 0.08, right, which is like the legal limit. So the drug concentration makes a big difference there as well, okay? That allows you to do things like strategic breastfeeding. Anyone know the term for that? Pump and dump, right? Very useful strategy, right? So that way you would pump all the breast milk you have at one point, and then you can partake of a particular substance, and then afterwards you get a lot of that substance to metabolize and get rid of it. So by the time the baby's ready to breastfeed the next time, you will dump that next bit of milk, and then you can go ahead and feed the baby again, right? So the pump and dump strategy can be used occasionally there. But Also, things like the pH of the breast milk can cause some of the ion trapping a little bit, so you can also see that where a drug can accumulate in the breast milk and then be transferred over to the infant. So anyway, so how we've kind of changed the labeling, the way we used to have it would be the pregnancy category, which would just tell you A, B, C, D, or X. We'd have some concerns about, say, labor and delivery, and then we'd have things about nursing mothers. The new way we kind of label things are going to be talking about pregnancy, labor, and delivery concerns. Because certain drugs can certainly do things like delay labor and delivery. They can prolong it potentially. We'll see things that are going to be falling into the lactation category, and then also now we have new labeling about the effects on the reproductive potential, right? So that's important as well because you want to worry about things like Accutane. Is that just a problem for women of childbearing potential? Well, no, you can actually see issues with the males being exposed and maybe transferring that over to the female, right? That can lead to some drug exposure. So those are things we get covered in that section as well. Okay. So just to give you an example, you would see here that pregnancy risk factor for warfarin, right? Warfarin is a vitamin K antagonist used for anticoagulation. You see here it's a D for women with mechanical heart valves, but it's an X for all other indications. What do you think it's a D for patients with mechanical heart valves?
Risk-benefit.
Risk versus benefit, right? So the risk with a mechanical heart valve is what? The risk is going to clot that thing off, right? Because again, it's a foreign material. Blood does not like to flow around that very easily, so you're going to get clot there if you don't have appropriate anticoagulation. So there could be a situation where the risk to the fetus is outweighed by the benefits to the mom being anticoagulated. Now, for everyone else, you don't really run into that situation. We'll talk about ways to anticoagulate these women. They're much safer than warfarin, but just to give you an example of how that can actually change depending on the clinical situation, right? And the nice thing nowadays is that it actually gives you much more detail. They say, okay, here's all the studies we have. Here's what we think is actually occurring here and what kind of deleterious effects you can expect to see. This allows you to, and again, it's tough because you actually have to do a little bit of reading. It's nice if you can just look at a letter and be like, X, I'm not going to use it. Or A, I'm going to use it for everyone. But do a little bit of reading and actually figure out, okay, well, what does this mean for my patient potentially? And that can be very, very helpful there. Another good example of this would be Ondansetron, right? Thinking about pregnancy-related nausea and vomiting is a big, big concern. So how do you treat that effectively? Well, we see here, okay, it's category B, so right off the bat I know, okay, well I know it's not, maybe 100% safe, but I know it's pretty safe for the most part. Not really any evidence to show it's going to be a big danger to a pregnant female, but let's look into it. Let's see what kind of dangers could be present. Talking about things like QT prolongation, talking about other things like that. And if you're looking at it like, well, my patient's not really at risk for QT prolongation, so I'm going to feel much more safe in using it, right? I'm using a little bit of critical thinking to apply it to this individual patient to say what's safe or maybe what's not safe. And then looking at things like, okay, whether or not it goes into the breast milk. It is not known if Ondansetron is excreted into breast milk. Okay, well, if you don't know, then maybe that wouldn't be the first thing you want to recommend if they're having some nausea and vomiting after birth. Right? So again, do a little bit of reading can definitely inform you on what could be safe or not safe for your patient. So anyway, so what are some physiologic changes that occur in a pregnant female? What do we think? Good, you're pumping blood for 2, right? So you got to have more blood volume. What else occurs? We're going to see things like renal blood flow is going to go up because, again, just more blood volume. We're going to see more flow to the kidneys. GFR is going to go up. Cardiac output is going to go up. So go along with that, heart rate's going to go up. BP typically goes up a little bit, right? Or hopefully it doesn't go up too much. Some women do get preeclamptic and develop hypertension, but hopefully just that increase in heart rate should balance out the blood pressure, but hopefully that remains unchanged. Those are big things to see with that. GI motility typically goes down, right? What's something that a lot of pregnant women complain about during, or some common GI complaints of women that are pregnant? Constipation is a big one, right? Which can lead to what kind of consequences? Trying to strain a lot to go to the bathroom. Things like hemorrhoids that can develop, right? So you can see secondary consequences of decreased GI motility. This hypercoagulable state, because again, based off there, things like estrogen concentrations are going to be going up. It's going to cause the liver to produce more clotting factors, can be something to be concerned with. We're typically going to see decreased albumin and weight gain associated with this, which means it can have an effect on volume distribution of different medications. So for instance, if you have less albumin, less protein, drugs that are highly protein bound are going to do what with their volume distribution? If they're not being bound up by serum proteins, they're going to be more free. They can then go out to the tissue. So the volume distribution actually goes up for those drugs. I know you guys probably thought you were done with volume distribution, but it always comes back to bite you, right? The weight gain, the more fat tissue you have, the more likely you have lipophilic medications are going to partition out more. So you have bigger volume distribution for those drugs as well. So we know there's a lot of pharmacokinetic changes that occur in pregnant women based off these expected and normal sort of changes in their physiology, right? So looking at what kind of drugs we're going to use in these patients here, obviously the best drug for a pregnant woman is No drugs, right? We'd like to use no drugs whatsoever. I know it sounds like an oxymoron. The pharmacist is telling you don't use drugs. What am I going to do about my job? But that's why I went into PA education, so that way I can always be rest assured I will have a job, right? Just kidding. So again, try to avoid drugs whenever possible. It's always going to be best as far as exposure goes. However, you need to consider, like, what were the chronic conditions they were dealing with before they got pregnant? Did they have diabetes before? Did they have bipolar disorder before? They have depression. Like, what do you need to do with that, right? And so the big thing to do is try to identify any kind of medication used prior to conception. Also, do pregnant women know that they're pregnant the day they get pregnant? No, a lot of times they don't know for a while, right? Just to give you an example, remember with my first daughter, we were very expectant, and so we were waiting for it, and we were testing for it all the time, saying, do we get pregnant this month? No, not this month. Do we get pregnant this month? So when we knew about it, it was like that. We knew pretty soon on. For our second one, we didn't know for a while. I was just like, man, you're really like feeling kind of run down. What's up with you? Why are you so sick? And she's like, I don't know. I was like, should we take a pregnancy test? And she's like, I don't know. I don't know if I wanted that. So I went to the dollar store. I got a $1 pregnancy test. Let me tell you what, that thing lit up brighter than anything I've seen in my life. So yes, sometimes you don't know for a while. You can be 12, 16 weeks in. Sometimes you get all the way to labor and delivery before you actually know you're pregnant in some cases. But you need to figure out what exposure has already occurred, right? So for instance, if someone was taking valproic acid as anti-epileptic or something as a mood stabilizer, and they didn't know they were pregnant for some period of time, that could be a problem, right? You have to worry about things like neural tube defects, right? And things like that that can develop there. So try to identify what they were on beforehand, what they might have been, the fetus might be exposed to already, and try to eliminate any non-essential medications. If you can switch them to something else, it's going to be a little bit safer. So if, for instance, they're taking, say for instance, they have a epilepsy disorder and you switch them, say, from valproic acid maybe to something like Keppra, might be a better option, or something like that, right? You want to be able to look at that and figure out, okay, what's going to be the best option for my patient there. Obviously, discourage any kind of self-medication. You need to make sure they clear it with you before they decide to prescribe anything for themselves. That's, again, that kind of more applies to a lot of over-the-counter medications and herbal products and whatnot. And obviously, if we can try to minimize exposure, it's always going to be beneficial. So either based off the dose we're giving, the duration of treatment, the route of exposure, etc. That can all be really beneficial to try to decrease the amount of exposure that the fetus has. So let's talk about some of the common maladies that plague, pregnant women and how ways we can actually deal with that. So what kind of drug selection we're going to be looking for women who are complaining some of these more common things we run into. So, some of them are going to be kind of more just annoyances in some cases. Some of them are going to be potentially life-threatening. So we're going to talk about all those ways we can help them manage that. So first off, nausea and vomiting happens pretty frequently. So what are some things we could do? We can look at things like dietary changes, maybe smaller, more frequent meals can be helpful here. But if that's not working, in a lot of cases it doesn't, what can we do to manage nausea, vomiting in a pregnant woman? What can you give them? So we're going to see, we have a couple different options here, right? So you don't want to jump strictly for the Ondansetron if you don't have to. Actually, I have a few options that are available here. One's pyridoxine, which is vitamin B6. Again, it's water-soluble vitamin, very, very safe for pregnant women. Actually, it's a category A drug. So we can actually use that, no problem. Doxylamine is also another one as well. What does doxylamine? It's actually a first-generation antihistamine. Anyone know the brand name for it you can find on the counters? It's over the counter. It's called Unisom. It's actually marketed for sleep. If you need sort of short-term treatment for insomnia, you could use doxylamine or Unisom. That's also a category A. Very good from that standpoint. However, if you're giving a first-generation anticholinergic, what other maybe common GI issue with pregnant women to have to worry about? Yeah, constipation. Why? Because it's an anticholinergic. Remember, that slows down the GI tract, right? Things to think about. So, in fact, there's a prescription product that they will combine the two together called Diclegis, B6 plus doxylamine. Very, very expensive though. I remember one of my docs that I worked with was taking it for her pregnancy-related nausea, vomiting. It was like $85 a pill she was taking it for. I was like, why don't you just buy it over the counter? Just buy the two separately. Do that. So in some cases it might be beneficial for them if they can just get like a much cheaper variety over the counter. It's the same stuff, right? Just get the same doses and you're going to be fine there. So that's one thing you can do. We could also use something like metoclopramide or promethazine. Those have been around for a very long time, so we have a decent safety record with these. However, you want to be careful, right? Because what do those drugs like to cause? Sedation, right? Sedation is a big thing you're going to see with those. So again, if they're still working, if they're going, trying to sit through school or something like that, they still need to be concerned about that. So sedation is a big problem. Also, you worry about those blocking D2 receptors, so you could see some of those extrapyramidal side effects as well, right? Again, depending on how significant their nausea vomiting is, the bigger the doses they're taking, the more likely you are to see those EPS effects, okay? Something to note. Nowadays, though, we do have the 5-HT3 antagonist, so Ondansetron is going to be the most common one. So what I would probably recommend for most patients is if they don't tolerate, say, the pyridoxine and the doxylamine, that's not working, then I would probably go ahead and try something like Ondansetron, right? Because those are kind of the big side effects of Ondansetron. You're right, really nothing, right? Not a whole lot. You have to worry about QT prolongation, but again, for most pregnant women, it's probably not going to be that big of a concern unless they had some kind of congenital history of prolonged QT. So again, it's more expensive than maybe buying a doxylamine and B6 over the counter, but it could be a useful second agent there. Okay. There's also granisetron and dolasetron, but really ondansetron is the one you're going to use far and away the most often there. Don't have a lot of data on lactation, so but usually by the time they've given birth, they don't have a lot of nausea, vomiting, kind of residual to that, but it will be a little bit more expensive. Again, we talked about these in GI, so kind of review that. You kind of know the big effects to look for with those agents. Is there any EPS you see with the 5-HT3 antagonist? No, right? Because where do you get EPS from? Dopamine blockade, right? So again, you'll see that's a big benefit with the 5-HT3 antagonist over something like Phenergan or something like metoclopramide. You see a lot less sedation and no risk for EPS symptoms, right? I guess saying EPS symptoms is kind of a little repetitive. Extrapyramidal symptoms. I shouldn't say EPS. Say that. All right, heartburn. Heartburn's another common complaint you're going to see with this as well. Again, smaller, more frequent meals can be helpful with this. Usually what we're going to recommend, if we can, is just use antacids, right? Because again, we mentioned as far as the pantheon of drugs for heartburn, antacids are the weakest, strongest, the wimpiest out of the bunch, right? You know, they're going to deal with the acid there, but then you have a lot of rebound acid production, so it's not good for chronic management of heartburn, but good for just kind of acute mild treatment, right? So you have things like calcium carbonate. We talked about things like sodium bicarbonate, things like that. Typically, we like to avoid sodium bicarb and avoid magnesium trisilicate. Why do you think we like to avoid the sodium bicarb? So say you're holding on to more of that sodium. You're also going to hold on to more water. What can that do to your blood pressure? It can increase it. What does that do to maybe some of the edema that they're developing? You can increase it, right? So again, be careful with, especially with a lot of high salt foods or something that contains sodium. You can actually increase their blood pressure and maybe some of that edema that they're developing there as well. Some of that, especially the lower limb swelling and whatnot, they end up getting, especially in the later stages of pregnancy. We like to avoid those. Calcium carbonate, though, could be a decent option there. But again, calcium more likely to cause what GI issue? Constipation, right? So again, think about what other kind of side effects you're going to get from these medications here. So if constipation is not a big deal for them already, then maybe it's okay. But if not, it could worsen that, right? Good. Carafate's going to work here. Remember, carafate just kind of coats the stomach and kind of help to provide a nice barrier against that acid there. And then certainly we do see the H2 antagonist can be used as a decent backup, right? So again, if calcium carbonate's not working, any of the antacids, you can use an H2 antagonist. Proton pump inhibitors, just because they're newer, they have less evidence for use, but we don't really have any evidence to show that they're going to be really deleterious. So again, if you had someone that had really, really severe heartburn, calcium carbonate wasn't working, Tums wasn't working, the Zantac wasn't working, then maybe a PPI might be a good option for them. And what are some examples of PPIs? Omeprazole, what else? Esomeprazole, pantoprazole, lansoprazole, right? So again, the prazoles that are going to be the PPIs we're talking about there. Okay, so as far as constipation goes, how can we manage this? Well, we can do things like increasing fiber. Water content in the diet is always going to be nice. A little bit of moderate exercise can be good. I'm not recommending they go out for a marathon or anything, but just a little moderate exercise. Maybe some walks are good there. And then typically we like a lot of bulk forming laxatives, right? That's typically the drug of choice. So a lot of your fibers and methylcellulose and things like that, mainly due to the fact that they're not absorbed. And so if they're not absorbed, they have no systemic exposure, which means no fetal exposure. So we like that from that standpoint. Things like stool softeners like Docusate can be very useful as well. Again, kind of a category C. We don't have as much evidence there, but it's probably safer for most women there. Little to no systemic absorption. And then things like osmotic laxatives are very safe as well. So things like polyethylene glycol or Miralax, very, very popular nowadays because it's now over the counter. Very safe to use for the pregnant women. Okay. You can use stimulants, but I recommend it very occasionally because we talked about you develop some tolerance to those over time, some physical dependence. We like to avoid those if possible. Okay. You do want to avoid things like mineral oil, enemas and things like that, because that can actually decrease the absorption of certain fat-soluble vitamins. And we said you don't want to mess with the fat-soluble vitamins in developing fetus, so probably avoid those. Okay. All right. For the hemorrhoids, The best thing you do to prevent hemorrhoids is to try to prevent constipation in the first place. However, we do have some topical products we can use. Now, we did have preparation A through G. None of those worked. So we had to resort to preparation H, right? What is preparation H? We didn't really talk about it too much in the GI section, but basically what it is a mixture of a corticosteroid, usually hydrocortisone, plus preparation H for the hydrocortisone, and usually phenylephrine, right? Because what is a hemorrhoid? This is blood vessels dilated, it's inflamed, it's painful, right? Again, from all that straining that you cause there. So by using the hydrocortisone, what does that you think that does? It's anti-inflammatory, so it's going to deal with the inflammation there. And then the phenylephrine, what do you think that's going to do? It's going to constrict it, right? Because it's what receptors does it work on? Alpha-1, right? Yeah, so alpha-1 receptors get activated. It's going to constrict that blood vessel, right? Other things you can use are things like Tux pads. Those actually contain witch hazel, which is an astringent. Which also is going to help that kind of contract that tissue there and can help to limit that. Obviously, if you can prevent hemorrhoids in the first place, it's always beneficial, but sometimes you might need a little bit over-the-counter help with that, and that's where preparation H and Tux pads and things like that can be very useful. Sitz baths can also be used potentially to help out with those hemorrhoids. As far as diarrhea goes, typically, your bulk forming agents are going to be useful here as well. So methyl cellulose, psyllium husk, etc. And then potentially you can use loperamide. We said loperamide works by what? On the opioid receptors in the GI tract. Remember, it doesn't cross the blood-brain barrier, so it's not going to cause a lot of euphoria or addiction or anything like that. But by working on those GI receptors, it's going to slow things down, right? So again, if they had diarrhea, that's going to be the drug of choice there. Okay, so getting into pregnancy-induced hypertension. So there's several different kind of categories here. So certainly you can have chronic hypertension for these patients. So this can be either pre-existing or maybe they develop it prior to 20 weeks gestation. And what's like a full-term gestational age? Like 38 to 40, somewhere around there, right? 37, 38, somewhere around there, right? So again, prior to 20 weeks, you can still consider that chronic hypertension. And then obviously you have gestational hypertension when you have the BP over 140 over 90. And that's in the absence of proteinuria. Because again, as the pressure continues to mount, that's where we're going to see more of that proteinuria. It's more concerning there. That's going to be after 20 weeks gestation. And then you have mild preeclampsia. This is where the proteinuria starts to come into play here. And again, you find this to be relatively common. And 6 to 8% of pregnancies can be affected by this, right? When you have severe preeclampsia, they're having even more proteinuria. The blood pressure is even higher. And then we really worry about when eclampsia develops, because what's the main manifestation of that we're concerned with? Seizures, right? So how do you think we're going to manage the seizures? Yeah, it's actually magnesium, right? So again, it's kind of an odd treatment of choice, but we're going to see how that's going to work for us. Anyway, so doing or treating the hypertension with non-drug management, obviously that's going to be recommended. If you can try to, limit their restriction or their activity restriction, that can be useful here. However, if they're laid in bed all the time, what can happen? On the slide, it's saying a VTE. Why is that? The stasis, but also what else is going on with their clotting? They're hypercoagulable. Why? All the estrogen they're producing is going to cause what to occur? Increase it, causing coagulation, yes, but how does it do that? It influences the liver. It causes more clotting factor production in the liver. Okay, estrogen causes clotting factor to be produced in the liver. That's why you see young women who are on oral contraceptives, they get VTEs. Same reason why pregnant women are hypercoagulable as well. We'll talk about ways to anticoagulate them in a little bit, but but again, the more they're laid up, the more stasis, more venous stasis they have going on, the more likely they are to develop a clot there. Stress reduction can be really useful. Again, I just find by telling people don't stress out so much, they usually have very good stress reduction, right? Just kidding, it doesn't work. So I tell my wife, just have some positive mental attitude, it'll be fine. And then she gets really mad at me, so I don't say that anymore. But exercise could also, some moderate amount of exercise can help as well. And again, decreasing sodium intake and things like that can be very useful, right? We'll also give them calcium. This is good kind of over-the-counter, kind of non-pharm way to handle this. It can help to reduce the relative risk of hypertension by about 30%, so that can be very useful there. And then we talked about magnesium being the drug of choice when they develop eclampsia, right? So they're developing these tonic-clonic seizures. This is going to be our treatment of choice. And you think, why magnesium? Why is that? So magnesium actually kind of works a little bit like a calcium channel blocker would on the blood vessels. So typically when you give magnesium, you're going to see the blood vessels will dilate and you'll see a drop in blood pressure. Okay. So I mentioned magnesium also a drug of choice for what else? torsades, right? So we're going to treat torsades with that. But here, you're going to be seeing very, very large doses. Normally, if someone's in torsades, they slam them like 2 grams of magnesium. That's usually enough to manage that. Here, they're getting like 4 or 6 grams of magnesium very, very quickly, something like 15 to 20 minutes. Now, another place you'll see magnesium being used pretty commonly is going to be in the treatment for asthma. Why do you think we use it for asthma? Because I said it works like a calcium channel blocker, so that means it's going to cause vascular smooth muscle to dilate. What other kind of smooth muscle could it dilate? The bronchial smooth muscle, right? So we can use it for, especially status asthmaticus, to kind of work as a bronchodilator as well. In fact, when we use it for asthma, we'll usually give them, maybe a maximum of 2 grams IV, and we actually have to give them fluids along with it because we worry about the blood pressure bottoming out. But again, if you ever work like on labor and delivery, like you'll see them slam huge doses of mag that make most other people very nervous, but they're like, yeah, we give it over 20 minutes, no big problem, because again, their blood pressure is already so high, you're trying to get it back down to where they're not having these seizures developing here. So that's going to be the treatment of choice. Again, these aren't treated like normal seizures, just like febrile seizures are not treated like normal seizures would be. And so here you'd avoid benzodiazepines and avoid things like phenytoin because these are actually known teratogens. We do not want to use these, right? Both of those are going to be category D. Could be some benefits in certain cases, but for the most part, we can use other things, right? So for chronic management though, so if you know they're hypertensive, maybe they haven't gotten to the eclamptic stage yet, what can you do beforehand? Well, we have things that are going to be, not known teratogens. It can be relatively safe to use, and we have things like labetalol is a really good one. We talked about that before as being a 3rd generation beta blocker. What kind of additional effects does that have, if you remember? Because it blocked beta receptors, but also blocked, actually had some alpha-1 blocking effects as well. So you see a little bit of vasodilation from that effect. So that's why we like it. It helps to bring the heart rate down, blood pressure down. And nowadays it's being used more commonly as kind of a first-line sort of agent there. So that's why we like it in a lot of cases. We have oral therapy. We can put them on chronically. We also have some nice IV therapies that we can use acutely to get that blood pressure down if we kind of brought them in so they're really hypertensive, and give that IV and knock them down pretty quick too, which is nice. We used to use a drug called methyl-dopa. It actually stimulated alpha-2 receptors. If you remember, what other drugs do we saw that can cause that? Or have we seen that can cause that? Remember we had things like clonidine and guanfacine. They activated alpha-2 receptors and they worked as sympatholytics, decreasing sympathetic outflows. So you see decreases in blood pressure, decrease in heart rate. Methyl-dopa basically did the same thing. It was kind of working like a false neurotransmitter to trigger those alpha-2 receptors, and you saw less norepi and things like that being released there. So used to be a drug of choice, kind of gone by the wayside a little bit in favor for something like labetalol. See a little bit better efficacious out of that. Other things you may see include things like dihydropyridine calcium channel blockers. We'll talk about some other uses for that in just a few minutes here. And then if you had a need for sort of rapid IV treatment, this is where things like nitroprusside and nitroglycerin can come into play, working as a kind of direct vasodilators there. Okay. Anyone remember what toxicity is kind of unique to nitroprusside? Cyanide toxicity, yeah, you actually get cyanide molecules there, so we'll give it with a drug called sodium thiosulfate to help scavenge that. But yeah, so those are other things to consider, right? So we have a lot of short-acting agents we can use to help keep the blood pressure down acutely if need be. Okay, moving into gestational diabetes. So again, this affects relatively few number of women, but certainly something. How do you detect if they are having gestational diabetes or not? You're going to do the OGTT. The original gangster tolerance test, oral glucose tolerance test. They basically have to drink this really nasty sugary substance, sugary Gatorade, and basically you'll test to see what the blood sugar is at certain time periods, right? So again, there's different time frames you can use it for. And so again, usually around the 24 to 28 weeks is when you're going to start to test for that to see kind of where they're at. Usually for most women, if they didn't have pre-existing diabetes, type 2 diabetes, they will then, this will resolve after pregnancy. But just know that when they have that, they are also more likely to develop type 2 diabetes in the future. Okay. As I mentioned, we do the OGTT. Basically, it's a glucose challenge. We give them a big bolus of glucose. Typically, do you want them to be fasting or non-fasting beforehand? Typically fasting, right? Because then you want them to be at their kind of their baseline, and you give them big bolus of glucose. And then you can either do, say, like a 2-hour challenge. A lot of people are now recommending the 2-hour challenge because it helps to limit the amount of time they're going to need to be there. Otherwise, they may need to do like a 1 and a 3-hour challenge. Okay. And again, depending on how the 2-hour challenge comes back, if it's kind of marginal, they may need to actually go back and do a longer 3-hour one potentially. Basically, once you hit a certain threshold, which I'm not going to test you on, if you exceed those thresholds, you're considered to have gestational diabetes, and you have to kind of follow up with a specialist, all that good stuff. But other things you can look at, if they already had a high A1C beforehand, their fasting glucose is already super elevated, it can be other clues that they have gestational diabetes. So how can you manage gestational diabetes? What do you do? Well, diet could always be the #1 thing you can do, try to help get that under control. However, insulin tends to be the drug of choice for this, right? And so insulin is a category B, should be relatively safe, right? Because what do we all typically produce? We produce insulin, right? So again, if you can replace what they don't have enough of, that can be probably the safest out of the bunch. You have other, and we haven't talked about this, and we haven't covered endocrine yet, so we'll get over, talk about all those different medications to help manage hyperglycemia. But things like metformin, glyburide can be used occasionally, but we don't have as much evidence for safe use. But definitely with insulin, we know that's going to be definitely the safest out of the bunch. Now, how do you have to give insulin? Sub-Q most often, right? So sub-Q, and so again, that carries a lot of stigma along with it. People get needle phobic. It's a lot more labor intensive. So obviously that's going to be something that a lot of patients are going to be relatively hesitant to do. So again, if you can get away with just dietary modification, it's always going to be beneficial. However, you may need insulin in some of those more severe cases. Talking about the venous thromboembolism, we mentioned that the VTE risk goes up about 5 to 10-fold for pregnant patients here. And so we mentioned warfarin, we already saw, was a category X in most clinical situations. So what can we use instead? Well, we mentioned what are some things that have a hard time crossing the placenta? What kind of molecules? Really big molecules, right? Remember we talked about unfractionated heparin is just a really long sugar chain. It actually has a really hard time crossing the placenta. So what we can actually use is either unfractionated heparin, the original heparin, or we could use things like low molecular weight heparins like enoxaparin. Those actually have really good ability to anticoagulate the mother without really having really negative effects on the fetus. Warfarin is typically going to be avoided in most cases here. And then if they do have a VTE while pregnant, typically what they're going to do is they'll be on anticoagulation throughout the pregnancy and then typically 6 weeks after delivery. So hopefully get a minimum of 3 months. If not, you may extend it out a little bit longer past delivery. At that point, once the baby has been born, they should hopefully will have their estrogen levels kind of drop back down to normal, and then they should be able to decrease clotting factors and kind of get back to their baseline essentially. But by having that therapy there for the longer period of time, you're going to be able to keep them from being at the higher risk. Now again, I haven't looked at it too recently to see if they're starting to use more of the anti-10A inhibitors, like rivaroxaban and apixaban and things like that, but that's probably going to be the direction we're moving towards for chronic anticoagulation for these women. Because again, how do you give unfractionated heparin and low molecular weight heparins? Sub-Q, right? So again, that's obviously not great from an administration standpoint, but if we could use something like rivaroxaban orally, that's going to be preferential, right? Okay. Other things. So how about UTIs? If they're asymptomatic, they have bacteriuria, what do you got to do with that? Got to treat it, right? Got to treat it every single time. So this is where things like nitrofurantoin can be useful. This is a category B. Unfortunately, it does not cover Proteus, so once you culture that out, it'll work for most cases of UTI, but if you culture out Proteus, it would not cover that. You'd have to switch over to something else. Moxicillin, cephalosporins tend to be category B. Very good coverage for most UTI bugs. Moxicillin, you gotta be a little bit careful because if it does culture back E. coli, it could be resistant to that. So just be aware of that resistance pattern there. Again, all of them are gonna be compatible with breastfeeding, so they have a UTI after giving birth. All those are gonna be very, very safe for them. As far as pain goes, acetaminophen is going to be the drug of choice. It's considered a category B. We mentioned NSAIDs can be used, but really only during the first and second trimester. The reason why we were concerned about it, and actually goes to a category D in the third trimester, is because we worry about premature closure of the ductus arteriosus. Have you guys covered fetal circulatory system yet? Long time ago, right? So you know it changes quite drastically between when they're in the placenta versus when they are born. And so basically they need that ductus arteriosus open so that way they can circulate the blood effectively. When they're born and they can start to use their lungs, that will eventually close off. If we close it off prematurely, they're not going to be able to circulate blood effectively, and that can be very deleterious to the baby there. Okay. Does anyone know what we can use to close a patent ductus arteriosus, say in the NICU? You can use IV indomethacin, or actually nowadays we're using more IV ibuprofen. Actually, the manufacturer of IV ibuprofen bought up the people who made Indocin and made it so expensive that they had to use ibuprofen to cover those costs. Big pharma, all evil, all about the money, right? Anyway, morphine can also be considered safe in some cases, especially first, second trimester. However, if you can limit opioid use, that's always going to be very beneficial, right? So again, try to limit how much drug exposure you have here. With higher doses or prolonged use, becomes a category D mainly due to the fact that what's going to happen to the fetus? They're going to become physically dependent on it, just like the mother may be physically dependent on it. So when they come out of the mom, they're going to be expecting that drug to be around, and when it's not, they're going to get pretty fussy, and they're not going to eat well, and they're not going to be able to regulate their vitals very well, and so they become very difficult to manage. So neonatal abstinence syndrome is what that's termed as. So what do you think we give them to help them with that neonatal abstinence syndrome? If they're missing opioids, we give them some opioids. We actually put them on methadone. We actually have little infants who are on methadone to help wean them off of it over the long term. We can also give them things like clonidine to kind of help them with that sympathetic outflow. But those are the main ways we help to manage that. So if they're missing the drug, and we give them the drug back essentially, just at smaller doses, and we wean them off slowly. Okay, so then looking at mental health during pregnancy, one thing that actually can help with this, I find, is that if you are ever in the presence of a pregnant woman, as a male, just take a vow of silence. I found that helps out greatly, because I've said some very dumb things during my wife's 2 pregnancies that I immensely regret, because I still hear about them to this day. So just shut your mouth before you say anything you don't regret. I had this one really profound moment when my wife was like, getting ready to have my first child, and I was like, wow, you think about it, like, I'm always going to be like her dad, like, like I might not always be your husband, but like I'll always be her dad. And boy, that was I had a very sweet sort of sentiment behind that. And boy, she was like, well, what do you mean I might not always be your wife? It's not smart, right? So just shut your mouth, you'll be good to go. Anyway, we do know that mental health issues are more predominant than we probably originally thought, and it's important to make sure we have a good, be able to have open conversations with that, right? Try to get rid of some of those stigmas associated with, dealing with depression and anxiety. We should just say, oh, you just get the postpartum blues. That can be really significant, right? It can lead to things like suicide, harm to the infant, a lot of issues with this, right? So now we're realizing that we need to be treating more of these patients, especially if you think about suicide risk and things like that. Like, well, it's probably safer to treat the mom throughout the pregnancy and worry about the possible effects on the fetus later. We'll talk about some of those effects that can occur in the long run. Now, again, a lot of women will tend to discontinue use of all medications, right? Because what do they have? They have mommy guilt, right? And so mommy guilt can be a very difficult thing to deal with, because they say, I don't want to take anything. I don't want my baby to be exposed to anything. Sometimes you need it, right? So sometimes you have to have that conversation. It can be kind of difficult, but if you can kind of work them through it to be, listen, this is going to be best for you, and what's best for you is also best for the baby. That can be a good way to kind of frame it. But anyway, we realize that about 10% of childbearing women will have postpartum depression, and usually occurs within that first month or so of childbirth. If you think about it, like, their hormones are going all over the place. They're going from very high amounts of estrogen and progesterone now that the baby's been born and they've lost the placenta. Things are dropping back down precipitously. That can sometimes influence it. That pre-existing depression, anxiety, that can also influence it. So a lot of issues going on here. And again, we have more people being willing to recognize this and more willing to treat this, and so that's a very important thing to consider. And the treatment of choice for this is going to be our SSRIs. Now, of course, we could use things like TCAs, we could use things like SNRIs, but by using an SSRI, it's kind of the cleanest out of the bunch as far as this mechanism. Very, very specific for what it's doing. Very, very good from that standpoint, and it's probably got the best safety profile out of the bunch. Okay, any of them can be effective agents here, so it doesn't matter if you use Zoloft or Paxil or Prozac, or any of them are going to be totally fine. Paroxetine probably not going to be the best one recommended here. There is some of an increased risk for cardiac malformations. We don't like that one quite so much. Most of the other ones are going to be pretty safe for the most part. The only thing we do worry about are the possibility for having pulmonary hypertension. There is a slight increase in risk for pulmonary hypertension in the infants, but again, you got to weigh the risk versus benefits of treating the mom versus what could potentially happen for the fetus there. Also, if the mom is exposed to, say, an SSRI all the way throughout pregnancy, and then the baby's born, and say, for instance, in the NICU and they're not being breastfed, what can happen to that baby at that point? They can have a discontinuation syndrome, just like the mom can have discontinuation syndrome. If she goes off of her SSRI, the baby can have the same thing. And so, again, it can look a little bit like that neonatal abstinence syndrome, where, again, they get very irritated. It's not going to be as severe as if the mom was doing, say, heroin the entire pregnancy, but it is something you got to be concerned about, right? And so if they're still being breastfed, we do still see some transfer there, and so the baby can still be exposed to it. But oftentimes we'll see, like, where the mom is taking it all the way throughout pregnancy, and, like, for whatever reason, the baby ends up in the NICU, and the mom can't breastfeed for whatever reason. That's where you start to see some of that discontinuation syndrome pop up. Yeah. Just something to consider. We could use a TCA, but again, think about some of the other effects there as well. So again, what could TCAs do to the GI tract?
Diarrhea or constipation?
Mostly constipation, I should say, right? Because it's anticholinergic, so you're going to see that. What's it going to do to their mental status? Sedation, right? So again, if they need to work or go to school, that's going to be affected, right? So again, there's other effects with the TCAs we don't like, and so that's why we want to stick with the SSRIs from that standpoint. Okay. All right. I think I'm going to go ahead and cut it off there. Let me check the board. Any questions before I conclude this class period? Give you a little bit of a break before lunch. Are you guys okay with that, or do you want me to continue on? Okay. As my Valentine's Day gift to you, I will stop early.